All right. Well, welcome everybody to the third webinar for the Aged Care Impact Series hosted by Digital Health CRC. I'm Sam. I'm the Comms and Engagement and Events Manager here at Digital Health CRC. And I'm very excited to welcome you to the third webinar. We have a few key people joining us online. Megan, Tim, Ilya, Murray, Isabel, Yana. You'll all meet them throughout the presentation. I'm just going to kick off with some little bit of housekeeping and then just get straight into it, I suppose. So today's webinar is being recorded and we will share that with you hopefully by the end of the day, if not tomorrow morning. And we do have recordings from webinar 1 and 2, which we can also share with you. Pop your questions in the chat and we will cover them at the end with the Q&A. And of course, to avoid disruptions, we'd ask if you can just pop yourself on mute and then come off mute if you have a question when we're going through Q&A. Just to kick off as well, I'm going to do a quick acknowledgement of country. So in the spirit of reconciliation, the Digital Health CRC acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So I'm going to hand over to Megan Schnewen. She's our Senior Program Manager and Aged Care Strategy Lead here at the Digital Health CRC, and she's responsible for driving this initiative. So welcome, Megan.
Thank you, Sam. Appreciate it. Rookie error, started on mute, so hopefully the session gets better. Thanks for joining us here today. We are really excited about hosting our third webinar and talking to you about this initiative. I am joined here by a cast of thousands. So I do have colleagues on from the Digital Health CRC with Isabel Freen, our Director of Digital Health and Integration, and presenting today also alongside me will be Tim Blake, who is our Technical Advisor and Managing Director of Semantic Consulting. We've got a software development team and a development partner in Beta Software, and I have with me today Ilya and Yana joining us, and also presenting today is Murray Hargraves from University of Queensland. So we're here at our third webinar already. Time is moving so quickly, and we are here to give you an update today. So as per the agenda, we'll just do a quick introduction and recap, introduce Connexus for those who weren't able to join us. We'll also be sharing some insights from ACDC, some benefits for stakeholders, plus a development update and demonstration from our development partner. We know that there is work happening within the department to produce an active, roadmap for the aged care data and reporting reviews. So phase 1 is underway now. Consulting is happening for that, and we are hopeful that using this time now to inform that roadmap, and hopeful that Connexus is a demonstrator of what could be done in a meaningful and sustainable way to progress digitisation in the aged care sector, moving towards standardised data. So what is Connexus? Recap for everyone. Hope I'm not repeating myself, but we are the Digital Health CRC have announced and are well underway in investing funds to build a production-ready smart on-fire quality indicator app. This is built off of the learnings and insights from the ACDC or the Aged Care Data Compare project. So we really want to demonstrate what is feasible today to technically implement a standardised approach to the collection of functional assessment data for older Australians. This is needed in order to improve data quality across aged care, but also needs to be done in a way that vendors and providers can easily implement, which is key to our initiative. We want to produce this showcase with a specific objective of influencing government policy regarding the need for this standardisation in assessment across Australia. So it's being built now, between now and the end of the year, in order to influence that policy decision-making process. So we are moving with pace and purpose, and this slide just shares with you what we are building. So a reference implementation of functional assessment with a de facto standard of inter-array long-term care facility. We're deploying this within clinical information systems using smart on FHIR launch capability, building once and deploying many times. We're pre-populating that with as much data as we can from the aged care clinical information systems. And we are supporting a process to aggregate, de-identify, review and submit the QIs as per the government B2G program. So the basis for Connexus and how we sort of got here, as I mentioned earlier, was from insights generated from the Aged Care Data Compare project. I thought it would be helpful to underpin and share knowledge about what those insights were to underpin the conversation today. So I'm going to share the stage with Murray Hargraves from University of Queensland. As Murray goes through the use cases or scenarios, if there's others that you would like us to consider, please put them in the chat or feel free to email us at the end of this presentation. So over to you, Murray.
Thanks, Megan. And if you can't hear me, please put up your hand or shout or do something. Yeah, so thanks for the introduction. So yeah, my name's Murray and I was the manager and coordinator of the Aged Care Data Compare projects. We had two projects over the span of a few years, funded by the Digital Health VRC. So I'll just talk about several overlapping domains of interest that were the focus particularly of the second project. And these were robust assessment of a person's abilities and needs, which is a core component of good care provision, particularly in aged care. Good assessment leads to high quality data, and that high quality data then makes tools such as the Connexus app particularly useful. Both high quality data and useful tools lead to quality care or support quality care, and quality care leads to good outcomes. Another domain of interest was the use of outcome-based indicators of quality at the point of care. So we have a mandatory quality indicator program in Australia, but we were interested in using having those quality indicators used at the point of care. So this is the same data, but multiple uses, and it also strengthens the sector monitoring function of those quality indicators. The third domain of interest was, again, the use of those QIs at multiple internal levels within a provider. So again, the same data, but multiple uses, and then the ability to use existing measures for many organizational purposes from care level outwards. So we designed 3 pilots. We co-designed those with our industry partner, Regis Aged Care. The first was an assessment of workflow, a pilot looking at resident assessment workflow and looking to strengthen existing assessment practice. The second was an app, with much in common to the Connexus app that's going to be shown in this webinar. And that was built on the same modern approaches, smart on FHIR standards. And this app in our particular project gave a person level view of quality indicators, and this supported care level staff. So again, reuse of existing data and supporting robust assessment. We also co-designed with Regis a QI dashboard that allowed sophisticated views of the quality indicators. And so this was useful for multiple organizational purposes. And again, this is reuse of existing data and closes the loop between a robust assessment and data gathering process back to other organizational purposes which uplift care. Such a QI dashboard could be fed by an app like Connexus. Thanks, Megan.
Thanks, Murray. I appreciate it. And I think we've got Sarah from Regis on the call. I'm just wondering, Sarah, if you had any reflections on some of these insights that we have gotten from the Aged Care Data Compare project, and whether you're willing to weigh in on the value.
Oh, absolutely. Thank you, Megan and Murray. And actually, just being able to be a part of the Aged Care Data Compare project was fantastic for Regis. Some of the high-level things that was of huge value that came out was certainly looking at that resident assessment workflow. One, it was a good opportunity to review that, but two, it really does underscore, and I don't think I'm talking out of school, our registered nurses don't come out prepared from a university level to do really good, robust resident assessments. You know, it's very acute care focused. There are nuances to resident level assessments. So this was such a great opportunity. And we had great work with the UQ team in coming in and doing that assessment practice, mentoring, and that communication and improving that workflow. But what was really exciting that came back is then when we piloted the Smart on FHIR app, and those RNs who had done the resident assessment workflow review, so we're getting more practice in that, we're then able to play in our pre-prod environment with Smart on FHIR. And the feedback from those girls when they could launch the app, it pulled in information from the multiple care assessments that you have in the system into one place, and at the end of it could flag where the resident was at risk in real time with a subset of clinical indicators. They were just like gobsmacked. They wanted it rolled out there and then, can we please start using this app now? That was the overwhelming feedback from the guys on the ground. So those two things together were massive. And then when we come to the dashboard, that really targeted the management level at the home and then those layers above. So being able to have that interactive dashboard for the GMs and the CMs who are responsible for the clinical governance and oversight of the home was really was fantastic. We had a lot of very good feedback. The fact that you could drill down to an individual resident and see where they flagged across all of the indicators for them as a manager gave them that ability to have better insights to make sure that we are driving continuous improvement for those residents, but also at that system level of their home to make sure they were able to then address those. Then for people like myself and my team, we're our clinical and quality specialists and managers. So we're now looking over a group of homes or at the national level. Then that gives us that oversight view of what's happening nationally and what are the levers that we need to pull from a system level within our system to get improvements. So that's just, was very enthusiastic about the outcomes that we had from ACDC Plus, and incredibly excited about this project and incredibly excited about Inter-I, if I want to be really honest and plug that.
Thank you, Sarah. We're grateful to have had you as part of the project, but it always is so important to get those user and consumer views firsthand. So thanks for sharing that with us today. And so I'll just share with Tim Blake now. Over to you, Tim. So Tim's our technical advisor at the Digital Health CRC and has been part of bringing together our technical architecture and making sure we're building on all the right standards. Over to you, Tim.
Thanks, Megan. Trust that you can hear me okay. Connexus very much stands on the shoulders of ACDC and really appreciative of the great work that it achieved. And thank you, Sarah. That was a really good summary and good to understand that that work is appreciated in the real world. As we crafted this program, we wanted to think very carefully about how we could design the scope such that every group of stakeholders got some benefit of doing this. And I want to take you through just for a few minutes how we think that's the case. I think it's important to remind you that the scope of this project at this stage is only going to encompass a small number of vendors and a small number of providers. But what we're doing here is being designed so that potentially it could be rolled out on a wider basis not too long after the program concludes. So we're really designing this with the whole industry in mind. I think it's very easy, isn't it, to forget the resident in all of this as we talk about the different stakeholders and their urgent needs. So I think from a resident perspective, there are significant benefits here as we move towards a way of doing functional assessment. There was a question in the comments about whether this is for at home. Connexus scope is long-term residential care at this point in time, although, there may be opportunities in future phases to look at that. But it's an opportunity to bring standardised functional assessment into aged care, which, as Sarah said, I think is really important. That standardised assessment has been studied, validated, and is an excellent way of doing functional assessment in aged care. But the benefit of this then is if providers and vendors participate in it, those assessments, as residents do sometimes move between care and levels of care and different providers, those assessments will be shareable. And that's really important because those assessments can also be used to pre-populate future assessments, thus reducing the workload and driving standardisation into an industry where workforce is already a challenge. And by standardising some of the common tasks for nurses and carers, this is really going to help if people understand functional assessments and don't have to do a different one in each place that we go to. We think that will help vendors as well by having these kind of standardised assessments, and it will give us confidence over time to build increasing levels of clinical decision support and just general decision support as we understand concepts much more clearly, and I think can safely build in that way of driving triggers and things that will drive reminders and more common process across aged care, which I think will also benefit, most of the groups here, including workforce. Pre-population, because of the proprietary nature of the way that data is captured in different vendor systems, may be relatively limited to start with in the Connexus app. But over time, we will obviously be able to pre-populate not just from data in the systems, but also from data that is written back from functional assessments into systems and from previous assessments as well. So I think pre-population, we've got modest views about what we can achieve to start with. We have to be realistic. We can't pre-populate things if it's not the same, and it would be dangerous to do so. But we think that the ability to do that will grow over time. And I think it gives us the opportunity to compare assessments over time as well and take a more longitudinal view as we have this standardised way of doing functional assessment, even if residents move between care facilities. I think the other goal here, and one of the ways that we've tried to balance this program, is by also helping government and by taking the functional assessments that are done in Connexus and adding a workflow that aggregates, de-identifies, and then converts to the form that government want to receive QIs in. We will then be able to submit a subset of the QIs required. Obviously, there's some technical work associated with doing that. We will be working collaboratively with aged care providers to look at what those workflows look like, because obviously we don't submit aggregated data without having a good review of it first. So we'll build in some of those processes, but being able to increasingly automate those processes is not just a benefit for providers, but it's a win for government, who have spent money on developing these APIs and now want to see significant uptake of them. I think we're also thinking about moving data into a much more standardised framework, and this is where FHIR becomes potentially an underpinning solution for us, and we can build on a lot of the good work that the Sparked FHIR Accelerator has done. I'll talk about that a tiny bit more on the next slide. And I think, again, Sarah, to your comments around the workforce, I think really being able to standardise training is going to be incredibly helpful, and have a single shared conceptual model of the way that we think about residents and their needs. This is not going to happen overnight. We're not, but having a target that we can move to that is a validated target, I think, is a very good direction for the industry. The program also wants to leave a legacy with the vendors, and the legacy will very much be helping them to develop what is called smart launch capability. That simply is the ability to launch smart on FHIR apps, which requires a little bit of infrastructure work. But once it's in place, Connexus will be the first smart on FHIR app that they can launch. But there will then be others, and government is doing a lot of work. A lot of commercial providers are doing work on developing smart on FHIR apps for a range of solutions. So far, we've seen the cardiovascular disease risk smart on FHIR app produced. And I think we are heading in a direction where in the not too distant future, we'll have a national repository of smart on FHIR apps from which vendors in healthcare and aged care can draw down things that they think would help augment their solutions. That's a wonderful place to be in because it allows us to add stuff very, very quickly that is developed once and deployed many times, which is one of the mantras of this Connexus program. In order to do smart launch, we also need some kind of FHIR API. And again, the program will help vendors if they have not done that already with developing their own FHIR APIs. Again, we're very much standing on the shoulders of the Sparked program and the work that it has done there. There will be small tweaks and additions for aged care, but it is relatively marginal improvement compared to what's there already. And we think we're also building some infrastructure that will be a great test bed for future standardisation. So this project comes with a aged care software simulator that we can try some things in. Potentially even this Smart on FHIR app could be a global reference implementation for Interrise so that they could potentially deploy this in other countries as well with this code once deploy many times kind of mantra. And that may well then become a test bed for doing things we need to do in the future, like risk adjustment when it comes to QIs, because Interrise has long worked on these kind of things. And I think it would be an excellent future project to take the infrastructure and collaboration group that we develop here and potentially propose projects in that area. Finally, and some of you would have heard me talk about this at HIC when I talked on a similar topic, building on that Sparked FHIR Accelerator program, it turns out that although aged care has a lot of specific needs, some of the core of the way that we think about clinical data in aged care is very similar to the work that has gone on already. And we're very keen to leverage that. As I said, with a few additional extensions and new pieces of terminology, yes, new value sets. But I think we can use a lot of what exists already. We can also use some of the mechanisms that are proposed for smart launch and begin to hopefully develop a aged care stream of that Sparked FHIR Accelerator work, which is slowly picking up but may become more of a thing as we do this. So Megan, I'm sure that's raised a few questions. We have time for questions at the end, I think, but I'll hand back to you if that's okay.
Thank you, Tim. I appreciate it. So in terms of our timeline, we are well aware of other activity in the industry going on. We understand the large amount of regulatory compliance that is coming up November. This is why we are taking the approach that we are and progressing this with minimum as possible impact on providers and vendors. We have gone through June and July and hit all of the things that we had said we were going to achieve. And we will share an update now in relation to our current work, what's happening in August, which is we were already almost at the end of. So I have Jana and Ilya Beda to share and talk about the activities that we've been undertaking from a development perspective and the next tranche of activities on the go. So over to you, Beda.
Hi. Megan, could you please switch to next slide? Yeah. Yeah. So nice seeing all of you today. So for the last month, we got quite of progress in building Smart on FHIR application for Connexus and also aged care software simulator. So we have all the infrastructure prepared. We have defined like the cloud provider setup, which was Google Cloud, and now it's fully configured to host both solutions. Yeah, so we have some initial version of the architectures and the user story drafted. So now we fully understand the whole scope, starting from like launching the app, creating the inter-array assessment, and after that creating inter-array or not inter-array, a B2G quality indicator questionnaire for exporting. Yeah, we're also working with inter-array and creating LTFC assessment form. It is still work in progress, but we have something working that I am very excited to show you today. Yeah. Finally, we need to apply some UI UX design and start working with HK software providers to launch this solution in the environment. Yep. So now I'm going to share my screen and do some demo. Okay. Do we see my screen? I hope so. Yep. So here you can see a public open source repository for the HK software simulator. So unfortunately, like not so many HK software vendors support FHIR and Smart on FHIR. So we need this piece of infrastructure that fully compatible with Smart on FHIR and AU Core to be implemented for demonstration and testing purposes. So this part is fully open source. It's available on the GitHub. So if you're interested in launching this simulator in your local environment, yeah, just you can go here on the Kinexus AU GitHub organization and get it. From the architecture point of view, it works like this. HK software uses Smart Launch to launch the Kinexus application. We are using data pre-population, and I will demonstrate it later. With CDS hooks, we can identify HK software that assessment should be redone, and finally we can write some limited data back to the HK software and another stream is export data from B2G quality indicators API. Yeah. So HK software simulator looks like this. It is very simplified version of Veda EMR. It just contains list of residents, because for demonstration purposes we don't need anything else. Resident is represented as AU Core patient resource. Yeah, and for the patient dashboard, we have only basic information right now. The following piece of work is to map AU Core into inter-array assessment to define more resources that to define more FHIR resources that we can use for pre-population. And once it will be done, here in the document section, we will be able to create more documents and we will have more details on the patient dashboard. The main progress here, it is this Smart Apps tab. Here we have a gallery of Smart on FHIR application. We obviously have Kinexus here, and just for testing purposes, I have Smart Forms by FHIR, since it is kind of one of the first Australian Smart on FHIR apps, and just to check that what we're implementing is interoperable, we have also this Smart Forms here. So once I click on launch button for Kinexus, the Kinexus application will be launched. It will take context of my user, that is Ilya Beda, and the information about patient, that is Bilbo Baggins, with some basic demographics information that will be used in the form for pre-population. Let's proceed with launch. So since we are launching this application for the first time, we need to provide access to the requested data as part of Smart Launch. It is Smart and FHIR authorization built on top of OAuth, so it's pretty similar to when, for example, you log into some application with Google, you need to provide access to some scopes. In this case, we are providing access to some scopes in our HKR software simulator. Yeah, so I'm totally fine to provide this access, so I can proceed. And now I have can access application up and running. So we just have list of documents. You can see that we, from the context, we loaded information about the patient, and also we have information about the practitioner who is running the assessment. I can proceed with creating a new assessment, and it is still work in progress. We are going to add a lot of UI enhancements here. For example, we have this very long header with 17 items. It will be displayed on the sidebar. And as you can see, we have some basic data pre-population like first name, last name, and so on, and date of birth. Yeah. So once, unfortunately, it will take a lot of time for me to fill all this assessment on a call of 17 items. But once it is saved, we will have this in a list of documents, and also all assessments that we are starting filling in automatically saved. So if I go here, you can see that I have 2 assessments in progress. Yeah, again, still in the development, so some part will be enhanced. Yeah, and I can proceed with filling this assessment. Yeah. So basically, that's all from the development update and this short development demo. I'm happy to answer your questions at the end of this call. Back to you, Megan.
Thank you, Ilya. And we'll just jump us back to the demo. So thank you so much for doing that. So our call to action. So thanks for joining us here today. As Ilya had mentioned, I've put some details on this slide about the open source simulator on GitHub with some details up there. And as part of this webinar, we'll share these details via email as well, because we realise that you can't get down the long URLs that we've written here. So thank you, Sam. So our call to action is to get in touch if you have got any thoughts or feedback on this initiative. We would love to hear it. If you have additional user stories or scenarios, we would love to have those as well. And if you're looking to participate in testing, that would be great. So we have a new email address listed on the slide, connexus@DHCRC. If you would like to hear more about our journey in aged care and find more about Connexus, we've also popped a link in there. And all of this information, as I said, will come out, including a summary of today's website session. So that was all we wanted to share with you today. We do have loads of time to open up the floor for question and answers, reflections, feedback and comments. Over to you, Sam, to facilitate that, and putting on notice my co-presenters here today to join me in answering questions, Tim, Jana, Ilya, Murray and Isabel.
Thanks, Megan. Yes, as I mentioned at the beginning, please pop your questions either in the chat or just raise your hand. Just like Isabel, she's a superstar. She does have a question. She can come off mute and ask a question. Go for it.
Thanks very much. And can you hear me all right?
Yes.
Thank you, team, for the presentation. It's great to see the progress being made. One of the things that possibly has been omitted is, well, where's the progress within the CRC and our engagement with vendors and providers in aged care? And it's probably worth mentioning that we are in conversation with a number of providers who are really interested in this. Some of the conversation that they need to have is with their vendor to say, are you interested? Would you partner with us in either jointly observing the progress of the Connexus project or potentially putting your hands up to be part of the test beds. So we are encouraging providers to have those conversations with their vendor partners. We want everyone coming to this high-paced set of activity to be motivated. We're absolutely aware a lot of the reticence is due to the significant implementation of massive change that is going on, and we've heard that loud and clear from a number of vendors. Another reason why the beta team have built the simulator. But similarly, if you're a vendor and you have got a large production environment, which would be an obvious test bed, then we encourage you to have conversations with your clients, or perhaps tap us on the shoulder to have those conversations. Because again, the real build and the scale that we're wanting to achieve with Connexus on the ACDC work is to demonstrate that scale potential. But having said all of that, we are in conversation with at least 2 vendors who are enthusiastic, and part of the conversation that we're having with them, and Megan and Tim both outlined this, is in terms of what we're wanting to achieve from this project, is also to really whet the appetite and get the engagement of vendors around the value of Smart & FHIR and standards-based adoption of data standards. And so part of what we are offering to really is first cab off the rank vendors is the support from the expertise of the beta software team to really build that capability in the vendor technical teams. So I just really wanted to reassure people that we're active. We're not naming people at this point in time, but perhaps maybe Megan by next webinar will be able to showcase those participants in the call. And if I may just lastly comment on the in-home care element of this. I see a couple of in-home care providers on the call, which is fantastic. We know that similar conversations to around the benefits that Sarah outlined are occurring in either dedicated in-home providers or certainly residential providers who are already expanding into in-home. We're very keen to talk to you if you have an interest in participating. Tim mentioned that the current focus absolutely is very much focused on the residential care, but there's the beauty of Interact is that it's a composite set of data elements, and the in-home care data elements are a subset of the residential. So there's absolutely possibilities to either kick out a Connexus in-home care project, or as Tim said, expand the scope of Connexus to really pick up the in-home care conversation. So I don't know, Tim, if you wanted to add anything further in relation to that.
No, I think that's a really good summary. The one thing that was on my mind to add was, there's been a lot of talk about government mandates when it comes to data standards, and I think the other philosophy that's driving this project is one of pragmatism, that if there is intrinsic inherent value in doing this, we won't need to wait for mandates. We can kind of just move ahead with doing things that make sense. And so that may or may not ever come. We're in an industry that's full of change and doesn't want a lot more. But nevertheless, there is inherent value in what we're doing here, and we hope people will come with us on that journey for exactly that reason.
Absolutely.
Great, thank you. Does anyone else want to chime in on Sarah's question around, is there any work being done in the QI for support at home? Did anyone else have anything for that?
I think Isabel's answered that one, Sam, so I think that's good. Have we got any more coming through?
No more questions in the chat, but if, oh, yeah, there we go. Annette, feel free to come off mute.
Doing that.
And then we'll come to your question, Sandon.
Okay, it's not really a question, Sam. It's more a comment. I just like to call out what Sarah said from Regis. They've been a fantastic partner in this this work. And a few weeks ago, I participated in the final, what we call PCG, with the Regis team for the second phase of the ACDC project. And I got the same message from Philomena, who is one of their senior quality directors, and she said the work they did was just fantastic. And Sarah, you've certainly explained that well today. And Philomena said, you know, that the whole project was just absolutely amazing, and it has the ability to transform what we do in aged care. And I think, you know, at the end of the day, all of the technical discussion is important, but at the end of the day, the ability or the prospect of this being able to transform aged care is the reason why we started this work some 6 years ago. And certainly Isabel and I have been on the journey since then, and I've always said if there was only one of our legacies that we could leave behind, was that transformation in aged care, that this would be it. But ultimately, at the end of the day, it's about improving the care that's provided to individuals and their families. And anybody who's had a relative in aged care knows you know, what a demanding sector it can be, and anything to make, you know, the workflows easier and to provide more time for care will be, you know, just to such a gift. So that's really, I just wanted to leave that, and once again, just thank the team from Regis.
Isn't There's a question in the chat from Sandon. Can the application use current aged care data for QIs, or does it use only inter-array assessments? And will this add more workload to staff if implemented? Do they have to collect more data compared to what they are already collecting?
So I'll answer the first question, which is we're looking to pre-populate the inter-array long-term care facility assessment with existing data that's held in clinical information systems. So I think that's a vendor-specific activity for that one. And in terms of the workload when staff is implemented, so because we are doing a demonstrator, and it's not, you know, it's a production ready demonstration, it's not an implementation. I think the workflow that you're referring to there will need to be considered on implementation. So it is a point that we'll be addressing, probably not in the first phase in the first 6 months, but it is a user story that we have on the backlog there. Tim?
Yeah, just some further clarity on the QIs that we're working with here. So in talking with government, which the project has, you know, the representation we've been given, that the current QIs are fairly set in stone. So the aim is to map to those existing government B2G QI reporting mechanisms and definitions. Whether those QIs can evolve in line with standardised functional assessment over time is a broader question that I think the industry needs to discuss with government. But right now, individual inter-array LTCF data is going to be aggregated and then mapped to, and that process is a somewhat complex one, but some work is going on in that space, will be mapped to the current government QI definitions. That's the aim, and then submit a subset of those. This project won't cover every single QI that you need to, but it will cover some of them. Hopefully that brings some clarity.
Thanks, Tim. Isabel has noted that the beta team will be at the HL7 Connectathon next week in Brisbane. So just for a little promotion there, I guess, as well, if you're in Brisbane next week and you're able to head along to the event, if there's tickets still available, I'm sure you could tag along and see what FHIR software is doing. There's another question from Charles.
Yeah, I'll take that
one. Of the
one.
12 indicator. Yeah.
It's going to be producing, Charles, all of the QRs outside of those around, there's 3 or 4, Tim, around workforce and quality of life indicators, and there's one other one that doesn't come from the LTCF. So I will post the list of all of those with the minutes and the summary of today's meeting.
Yeah, and as I said before, there is a broader question about risk adjustment in that context. So hopefully some of this work will spark some of those discussions.
Thanks, David, for letting us know there's no more space at the connectathon. If there's no more questions and no one else is going to raise their hand, Megan, if you're happy, I'll close off.
Yes, more than happy. And Sam will share an email after this. So if you do have any other questions, there'll be an email address in that email for you to follow up with.
Beautiful, thank you. So yeah, that wraps up webinar number 3. Webinar number 4 has been, oh, hang on. Carrie, did you have a question? No? All right, I'll keep going. Webinar number 4 has been set in stone for September the 25th, same time, 3:30 to 4:30 Sydney, Melbourne time. And we've also locked in and set up all the other registration links for October, November and December. We've had a very productive week this week. So you can use the QR code. That will take you to the Connexus website, where if you just scroll down just a slight bit, you'll see all of the options to rewatch the webinars and to register for each of the next webinars. Isabel.
Well, I was just going to say what we will do is forewarn or publish what's going to be in scope for the subsequent webinars, so that if you're a vendor and you've got providers that are interested, please encourage them to come along and see see the progress that's being made, and vice versa. If you're a provider and want to bring your vendor along, please encourage them to do that. They may indeed have some other colleagues that they want to join. So we really want to sort of grow the interest and the understanding of what it is we are doing and what we're not doing. We are continuing to invite use cases. Murray's outlined 3 broad areas that we covered off in ACDC. We know there's a lot of opportunity for workflow efficiency in the current management of quality improvement, not just in the government reporting. So we'd really love to hear those use cases. Some of them we may be able to entertain in the time frame we're working on. Others will go on to a backlog. Please get involved. I've already got a couple of emails saying, how do we get involved? If in doubt, complete that, send an email, it'll arrive in Megan's inbox, the Connexus at digitalhealthcrc.com, and we'll be following up with you right away. Len has got a comment, so I'll hand over to you, Len.
Yeah, sorry to extend the meeting a bit, but there's a question in the chat that hasn't been answered, which I'm happy to answer if you'd like me to do that.
And the in-home care quality indicators?
No, this is about can the current application do all the QIs? I think we can do nearly all of them, and they should be able to be configured so that they're reportable in the correct format by making some adjustments and additions to the inter-ILTCF. So that's that's the first question. The second question is about workload, which we didn't discuss, and that is the INRI assessment is a comprehensive assessment. It has 250 data items in it, and the QI data set is about 70 at the moment. So it is, however, most providers are collecting way more than 250 items at the moment. If you look at the software solutions, a lot more. And much of what's in the INRI LTCF is actually consistent with what is in existing offerings. So there's an opportunity to substitute INRI data items for existing data items, in which case there could even be a reduction in the amount of data that's collected. So that's a matter for host vendors to configure their software and make it compatible with the data standard that INRI offers. So I think that answers the question. There was a time when 250 items would be considered to be a nightmare. That was 10 years ago. Now, when you look at most software systems, you find way more than 250 data points in an initial assessment. So something to think about. Thanks. Thought I should say that.
Beautiful. Thanks,
Thank
Len. And I'm terribly sorry if you can hear my dog in the background. My sister and niece have just arrived. So yeah, that wraps up webinar number 3. And as I mentioned, 4, 5, and 6 and 7 are all coming up and ready to go and ready for you to register early. So jump on user QR. Otherwise, the link is in the chat that you can access. But otherwise, thank you for joining us today, and we will see you next month.
Thanks, team.
Thank you.
Thanks, everyone.
Thanks, everyone.
Thank you.
Bye.